So I'll be talking on strategies for no portal flow in pediatric liver transplant, and I think most of the centers where pediatric liver transplant has been carried out, this is scenario one faces sometime or the other. So my slide not moving. Okay, so portal flow is the dominant inflow, and literature states that more than 50 to 150 mils per minute per 100 gram flow one should try to achieve during the implantation, and a low portal flow would lead to an early graft dysfunction or a thrombosis. So before I go on to why this may be occurring, I first want to start with if you have a situation where you have a portal vein thrombosis and it is not getting rectified by reanastomosis and all, so we have developed a technique for portal vein stenting in such patients. What we do is that in the donor we will recanalize the umbilical vein before explanting the donor liver. This is a reduced left lateral graft. You can see the umbilical vein. We'll put a bulldog. We'll cut the umbilical vein about 5 centimeters above, and it is pretty easy to separate the areolar tissue, and you take sutures with 6-prolin. The umbilical vein really opens up very nicely, and we establish a communication with the left portal vein in the donor itself. Then we explant the liver, and if we are faced with a problem in the recipient where we are unable to establish a portal flow, there we do portal vein stenting through the umbilical vein. So we have now around close to 300 plus pediatric liver transplants. In the initial era of our transplants, in the first 100 patients, it was a learning curve. We had a lot of issues. Sorting out each and every issue took time. So in about 8 patients, we had resorted to a portal vein stenting through the umbilical vein, wherein through this umbilical vein, which we have already recanalized in the donor, if we land up with the problem, we would pass a carotid stent through it. So this is just a short video showing the same. So here, this is the recanalized portal vein. We pass a suction catheter. This is a very convenient way of doing a thrombectomy if you ever end up in a situation where just passing a suction catheter through this umbilical vein, you can do a thrombectomy. But if you have a situation where even after that, again, thrombosis is occurring, I don't think one should waste too much of time. It must be an angle problem if you have already ligated all the collaterals, and their stenting would sort out the problem. So we will pass a Terimo guide wire. We use a carotid stent with a 6 mm one end and 8 mm the other end, and obviously an interventional radiologist is involved. And so here the guide wire has been passed into the SMV, and we'll do a check venogram. You can see the flow is not going well into the SMV and into the splenic vein, and that is because there's a thrombus there. So after having done a suction thrombectomy, we'll measure the length, and then I'll just and we'll pass this stent across through the umbilical vein. And it is at least in our initial period when we were going through our learning phase, we never actually ended up coming out of the theater with no portal flow. Always we could establish a portal flow with stent. And in the end, this is a stent being deployed, and towards the end of the procedure, we would put hemorrhoidal. We will put a KMP catheter in it so as to heparinize the portal vein, something which we have not done now in the past 200 plus pediatric transplants, and we would pass a hemorrhoidal band over it, so that in the post-operative period on 5th or 6th day we can just pull the KMP catheter out without risk of bleeding occurring. So in the end you will just see so this is the hemorrhoidal band we are applying. Usually we apply 2 or 3 bands that stops the whole back bleed which may be occurring. And through this KMP catheter, we would heparinize for a few days and then stop. So, but why it is happening, you should avoid best approach is prevention. It may be because of a large for size graft. It may be because of portal vein compression from the surrounding lymph nodes. It may be because of portal flow diversion, because of the spontaneous shunts being present, or a too small caliber of the portal vein, which sometimes you will come across in a biliary atresia child, particularly when they are post-Kasai. And then the technique of anastomosis also makes a difference, and improper angulation of the graft, which I think is a very, very important factor in this thrombosis occurring. So what we are doing for a large for size graft, almost out of 320 patients, 322 patients, we have done reduced left lateral grafts in 172. Right now, I won't go into the detail how we are reducing it, but basically we measure the length from the hepatic vein IVC junction in the recipient to the xiphisternum. And we have seen that when on radiology, when we measure the anteroposterior depth at this point in the donor, the anteroposterior depth is the same as that of the recipient. It never leads to a too thick a graft. So even for a 3.5-month-old child, when we have done, we have never resorted to a monosegmented graft, but we have never done a child which is less than 3 months old. So maybe we would require a monosegmented graft there, but for our practical purposes, we'll do I'm sorry for this, some part went unedited. So we will measure the same lengths from the IVC junction to the xiphisternum, what we had measured in the recipient on the donor liver after doing a left lateral sectionectomy. And then we will cut that portion of the liver so that this donor liver reduced graft will then sit in the recess in the thoracic part of the abdominal cavity, and it is covered by the rib cage, so that there is no fulcrum effect. When you're closing the abdomen, there is nothing which is compressing the graft to cause an abdominal compartment syndrome. It is not a random transaction here. We have to save the segment 3 pedicle very carefully, so that the remnant liver which is left after having reduced the liver is not ischemic. So this is a pictorial thing. That is the reduction we have done, and this is the post-operative CT. If you can see, the segment 3 pedicle has to be preserved so that the remnant liver is well perfused. So one aspect is a large for size graft. You have to reduce, be liberal. We have seen for less than 10 months old, we would generally require a reduced graft, and more than 10 months old, we may not. Second is the collaterals. You will many times come across a situation where you don't see the portal vein at all in a preoperative CT scan, the flow being diverted. But at least we have never seen a patient where there is a thrombus in the pediatric portal vein. It is always a compression. When we are operating, we remove the lymph nodes, the portal vein almost always opens up. And so it is important to address the compression on the portal vein from the periportal lymph nodes. So this was actually a 12, this was I think 10-month-old baby. I just recently took this video. So we remove all the lymph nodes surrounding the portal vein, and you can see that there is a huge coronary vein which is diverting the blood away. We'll ligate that as well in order to prevent any collateral flow. And this is a cleaned portal vein with a shunt ligated, and the artery also is similarly clean. So we remove all the lymph nodes surrounding the portal vein so that when the graft is being perfused, there is no angulation on the portal vein, there is no compression on the portal vein, which is, I think, is very important. Then we prepare the portal vein. We take the right and left portal vein about 0.5 centimeter to 1 centimeter stumps. We'll do a venotomy. And it's extremely important to get, I think pediatric transplant is a lot about angles, getting the angles right. So you have to very carefully take the sutures, corner sutures. So we'll take an anteroposterior and right and left sutures, and we'll check for the portal flow prior to implantation. But this orientation is important. We take the sutures prior to starting the implantation in order so that there is no angulation problems later on. Also, third aspect of this is to prevent a no-flow situation is to tackle the collaterals. Almost 80% of the pediatric transplants will come across a lienorenal shunt. In the anhepatic phase, we'll go for the lienorenal shunt. We always go on mobilize the left colon. We'll go onto the renal vein. We never ligate the left renal vein. This was a tiny shunt, but last minute video, so I took a video on this. Anyway, we'll come across a 3 to 5 mm shunt usually. And so we'll double ligate, we'll clip it, and we'll always cut it, because sometimes, if you are ligating and leaving it, it forms a nidus for thrombus formation, and that would migrate into the splenic vein. We've had a couple of times this happening, once in an adult, once in a pediatric. So we now always ligate and cut it. A better example, you can see the size of this shunt. That's a big shunt going into the left renal vein there. So we'll do that as well. Then there have been times when the vein is just too small. So we use cryopreserved veins, but we have also done autologous portal vein extension graft. We remove the recipient portal vein, we'll remove the right and left junction, and we'll combine the two to create on the bench to create a 1 centimeter wide graft. And though there is a compromise on the length, we will then re-anastomose it to the superior mesenteric vein SMV junction. I'll just skip it. So this is the graft we have created, and we'll re-anastomose to the SMV splenic vein junction. But again, this we were using in the initial part of our series, but now in the past 200 plus, whatever size of the vein, be a 2 mm or 3 mm, we have always been able to get a good inflow using that very vein itself. So this is the post-operative scan of that patient. I think another important aspect is the anastomotic technique. So this is the hepatic venous part. I'll just skip it. So for the portal vein, what we are doing is a posterior continuous suture, and so same goes for the hepatic vein also. I'm just skipping the hepatic vein part. A posterior continuous, will take a growth factor at the edge and anterior interrupted after having done a good venotomy. For the portal vein, I'm sorry, the video got... can you play the... So for the portal vein, the orientation sutures which we had taken earlier, on the graft we'll take the corners, and then again is the same technique as for the hepatic veins which we do. It's a posterior continuous endothelium to endothelium suturing. And on the edge, we'll take we'll leave a growth factor. Anterior layer will do interrupted. So and then again, a very important part is the fixation of the liver, so that the pediatric transplant is all about angles. Left lobe is all about angles. You should get your angles right. So carefully see the angle of the LHV, IVC, so and the portal vein. So I'm just concluding. This is our 322 patients. All our complications in the portal vein had been about total 13 in the first era, 2 portal vein thrombosis in the second era, where only suction thrombectomy was done and no stenting was required. So I would like to conclude with this, that classify quickly when you are faced with a problem, whether it's anatomical, technical, or hemodynamic. Manage the graft size, portal vein compression, collateral flow, autologous or cryopreserved portal vein graft. We don't use cryopreserved anymore. We have had post-operatively at few months, we have had thrombosis in them, so we stopped doing that. Technique of anastomosis and the angulation. And if you are stuck, then portal vein stenting always saves you, I guess. Thank you.